É que querem nem penwelin so doing out the chia. Stop no ha. You are the see do TV song. Do TV song.
Good morning, class.
Good morning, sir.
Good morning, sir.
Economic perspective, social development perspective, economic development perspective. Sustainability resource perspective.
No, could talk has been taken care of.
Inde dido ni. Inde ve. Ta kwe unde ni na.
Mrs. Bawa. Mrs. Bawa.
You guys can mute your mic. The lecturer is in the building.
Mm. Mhm. Mm. Mm. One of them. Mm.
Morning.
Good morning, sir.
Everyone.
Good morning, sir.
Good morning, sir. Good morning, sir.
Can you see my screen?
Yes.
Good morning, sir. So it can be put in the body. After it has been interpreted.
Before you give them, help me ask them their name.
Can you all see my screen now?
Sir. Yes, sir.
Yes, sir.
Okay.
Yes, sir.
It's okay. Good morning, everyone.
Good morning, sir.
Good, sir.
Morning, sir.
Okay. Let me be very quick to ask how many of us are in this class?
Okay.
Morning, sir.
Morning.
As of now, we are 14 numbers, sir.
No, the total number of students for this class, not those present online.
Sir, at least we are up to 65.
65. Okay, 40 is a good number, so we can start. So good morning, everyone, once again.
Morning, sir.
Good morning, Doc.
My name is morning. My name is Shimaka Andrew. I'll be interacting with us in this class on psychopathology. You rounded up the first component of this course with Dr. Dorothy Bende, and I'll be taking the second component with you throughout the remaining days of the week. So you all welcome to this class, Psychopathology.
Thank you, sir.
Thank you, sir.
Thank you, sir.
The course Psychopathology is aimed at helping us understand pathological issues that we encounter in the society, what they are, how they can be managed, and how we can also integrate or mainstream social standards into the understanding and treatment of pathological issues as we encounter them in everyday life. In the course of your discussion with Dorothy, you must have discussed what mental disorders are, what constitutes psychopathology, what does not constitute psychopathology. You must have also have studied what causes psychopathology. This morning, we basically look at the classifications of psychopathology. We in the course of the week of this series also be looking at specific pathological disorders, such as personality disorders. We also look at sexual disorders. We also look at childhood disorders. We look at emotional disorders. We look at anxiety disorders as time will permit us to look at them. The hallmark and the whole aim is to enable us understand what psychopathology is, what is the prevalence rate of psychopathology amongst us or within our society, and also how best we can be able to manage psychopathology, how we can also be able to identify and also link our social standards, the social standards within our environment with psychopathology and how social standards can help us, mitigate or reduce the impact of psychopathology on the society. Basically, for these slides, we'll be looking at mental disorders, significant, and then we'll also explore the distinctions between neurosis and psychosis, highlighting their unique characteristics. And we'll also look at their prevalence and their DSM classification. I know by yesterday you must have also understood what DSM is. The DSM, however, the DSM is the Diagnostic Statistical Manual of Mental Disorder. It is a manual that helps clinical psychologists also classify disorders and also distinguish one disorder from another. Are we together?
Yes, sir.
It's okay. So, what then? It's our understanding of neurosis. Psychopathology is divided into two broad categories. We have psychosis and we have neurosis. Psychotic disorders are major mental health disorders that have to do with a discussion of our touch with the reality. It implies that when an individual has psychosis, which is a major form of mental disorder, it affects his cognition, it affects his thought process, it affects how he interacts with the environment. It also affects his psychomotor skills. And that is psychosis. Neurosis, on the other hand, is the opposite of psychosis. It is seen as a mild form of mental disorder. Here, an individual suffering from this mental disorder, his reality is preserved. He does not lose touch with reality, but he's also aware that he has some pathological problems. So we'll look at what neurosis is as a form or as a type of psychopathology. And here we're saying that an individual experiences distress when he is diagnosed to suffer neurosis or when he is said to be neurotic. There is distress, but there is also touch with reality. So the individual understands his thought processes, he understands his mood, but there are also deviation from the normal. So they have insight into what symptoms they are suffering or they are presenting or they are manifesting, as the case may be. So if an individual is said to be neurotic, there are key characteristics that you'll be looking at that individual as being neurotic. What can help you identify a neurotic individual? First, you will notice that that individual is anxious. He suffers anxiety. And secondly, he also suffers what we call phobia. And then we also have what is called obsessive thoughts. And you also see him engaging himself in repetitive behaviors. We call these compulsive behaviors. Now, what is an anxiety? An individual who suffers neurosis presents himself with anxiety. He's anxious over everything. He's anxious, he's apprehensive about what will happen next, about what the situation may be. Now, he is not comfortable with situations around him. He is aware that this is the reality, but he cannot help himself overcome his fear. Now, anxiety has to do with excessive fear. This fear can be directional, and this fear can be non-directional. Directional in the sense that this fear can be tailored towards a particular object. It can be tailored towards a particular situation. It can be tailored towards a particular ailment. It can be tailored towards a particular person. So he notices, he observes, he is aware that he is having fear, but he's also aware of the reality of the situation. So it becomes abnormal, and it is said to be neurotic. Yeah, he's said to be neurotic. Now, when this individual fear is directed to key objects, we term it to be phobia. Now, individuals who suffer neurosis can continue with their daily routine in life, except when they presume or when the fear stimulus appears on the scene. He is able to withdraw, he is able to manifest certain symptoms or certain actions or behaviors that indicates that he is no longer comfortable with the feared stimulus that is presented. And this fear at times is tailored to a particular stimulus. Remove the stimulus, the individual is very okay. So when fears are tailored towards specific stimulus, we term them as phobias. And phobia is a mild form of mental disorder where an individual expresses fear towards a particular object, a particular stimulus. For instance, individuals can be afraid of public places. An individual can be afraid of public places. For instance, an individual can be afraid of animals. It could be cats, it could be dogs, it could be pigs, it could be goats, it could be anything. An individual may develop specific fears towards height. An individual may develop specific fear towards certain things. It could be night, it could be light, it could be water. He may develop fears towards these objects. These we call them phobias. Now, these phobias have specific names that are attached to it. For instance, an individual who is afraid of public places, we say he is suffering from what is called agoraphobia, fear of public places. If an individual is afraid of night or darkness, it is said to be nyctophobia. If an individual is afraid of water, because there is a large body of water, it could be streams, it could be rivers, it could be ocean, it could be sea, he is said to be suffering from hydrophobia. So there are over 50 phobias that individuals are afraid of. And ordinarily, it is not seen as normal for an individual to be afraid of specific objects. So it is termed a mental health problem. Now, obsessive thoughts. When an individual has repetitive thoughts that are running in his mind, these thoughts are repetitive. They are not going away. We say these thoughts are obsessive. He has become so obsessed. He has become so used to these thoughts that has gone beyond the normal. And these thoughts tend to some extent influence, increase his level of anxiety. It is called obsessive thoughts. They are obsessive. They mount pressure on the individual. They induce fear. They trigger, apprehension in the individual. Now, when an individual develops certain repetitive behaviors, now these behaviors are repeated. They are repeated not because there is a problem, but they are being repeated because an individual is presuming that something is wrong. We call them compulsive behavior. For instance, an individual who occasionally feels that his hands are dirty, washes his hands more frequently. They are called compulsive behaviors. Now, you will notice that an individual who engages in these repetitive compulsive behaviors is able to carry out his normal daily routine. But at each point in time, you see him washing his hands frequently. It is not seen as normal. It is seen as an abnormal way of behavior. So it is classified under a mild form of mental behavior that does not warrant or does not push the individual to lose touch with the reality of the situation around. Now, what distinguishes neurosis from psychosis as a major form of mental disorder is the symptoms or the characteristics manifested by the individual who suffers these disorders. And you will notice that for neurosis, our concern is that our emphasis is that the individual experiences anxiety. This anxiety does not prevent him from carrying out his daily routine. You will also notice that the individual in any way, in no small measure, is afraid of specific objects, but all objects or situations. He has identified certain situations that he's afraid of. We say he has developed phobia or phobic reactions. And then he has thoughts that are repetitive, that are reoccurring, but these thoughts does not in any way influence the way he does not he presents himself with delusions, hallucinations, and
Sorry, am I the only one who is not hearing him, or the network has thrown him out?
Maybe the network has thrown him out because I'm
I
not
can't
hearing
hear
anything.
him as well.
Because I think it's a network. Let's
All
be
right.
patient.
It was keeping initially before it even threw him out.
See the MIS machine on already. What's the name of it? Watching now, one hour long. Those who are
Then you don't remember.
what's the name one? So.
I I think he's struggling with the network because he logged in not long ago and then he has been logged out again.
Hello. Hello.
Here.
Yeah.
We're waiting for the lecturer. The network has thrown him out, so he'll be back.
It's all right. Yeah, play part one. You know, Bakavaga. Somebody some haiga. Pamagene yalo na ham pabeto mabelo they will not call you. I need you come here loga. Yes, I will believe.
Abu says to mute your mic. We are hearing your background talk.
Thank you, brother. I'll do that immediately.
All right.
Okay, are we back together?
Yes, sir, we can hear you.
Yes, sir.
Okay, sorry for
Welcome back,
the
sir.
net. Thank you. So just like we were saying before, the network instability. Individuals who suffer from neurotic disorders, can be differentiated on the basis of the symptoms they presented. These symptoms are mild, but they do not in any way them from carrying out their daily routines. One noticeable thing that you will notice is that there is absence of delusions. Delusions are prominent features of psychotic disorders, and they are said to be false perceptual beliefs. They are false perceptual beliefs that are peculiar, to the individual. Delusions. The individual experiences them and they affect his normal routine. You also notice that they don't have a cultural base. These delusions don't have a cultural base. Every individual comes from a culture, and there are some cultural belief systems that the individual or his culture or his society holds dear to his heart. But the presentation of his symptoms are actually a deviation from the cultural basis or the cultural foundation of such an individual. So basically, one thing you are going to notice that will help you distinguish an individual who is neurotic from an individual who is psychotic is the absence of delusions. First, you will notice that this individual to have reality. Knows that these are the correct things, these are the societal head of big. But you will also notice that he is unable to express his fear. The fear is there, but he has touched with reality. Secondly, there is absence of delusions. Delusions are false perceptual beliefs that an individual has that are peculiar to him and they are not ascribed to another individual. Then you also notice the absence of hallucinations. Hallucinations are also false perceptual beliefs without proof. He has experiences that are peculiar to him, not to other individuals. So as we begin to discuss psychotic disorders, we begin to see the manifestation or the influence of delusions, perception, and how
She's not hyperactive. She didn't even express
suffering
when it's
Olima Juliet, please mute your mic now, please.
I cannot hear for now.
I'm not hearing anything too, Mr. Jigba.
His network threw him out now until he logs in again. Olima Juliet threw him out again. Is she the network?
My sister Mimi do. How are you?
Right, he says good morning.
Morning.
Yeah.
I almost responded to differentiate the middles.
Oh.
This network should allow us to learn now.
Like seriously, this is an interesting lecture.
This network is almost sky. It's too bad. Come on. Should improve now. Okay.
Okay. Welcome back once again.
Thank you, sir.
I'm trying to see how I can change from this network to something else. Moving on from where we stopped, I'd say that what is going to help us to distinguish a neurotic individual from a
Excuse me, sir. Sorry
psychotic.
to interject.
Are we together?
Excuse me, sir. Sorry to interject. At some point, we couldn't hear you for 2 minutes. So can you kindly go over the slide again so that we will be on the same page, sir?
Okay. What we have
Sir?
just succeeded in doing this morning is that we are saying that we're looking at classification of mental disorders. And I say that there are basically two classifications of mental disorders. We have the psychotic disorders and the neurotic disorders. And we say that psychotic disorders are major mental health disorders that result to distortion in reality. And while neurotic disorders are the opposite of psychotic disorders, they are mild form of mental disorders that preserves an individual's touch with reality. So an individual who suffers psychotic disorder loses touch with reality. He presents symptoms such as delusions, hallucinations, thought disorganization or disorganized thoughts, disturbance in psychomotor activities, and a host of others. And I will say that going forward, we'll be looking at what neurosis is, and we that there are basically 3 or 4 characteristics we're going to look at in a neurotic individual. And the first one we see is that the individual is
Haba now, why are we behaving like kids? We are all adults. If you know your background is not safe for the class, mute your mic. What is big about muting mic here? Haba now.
Hello, class.
Yes.
Good morning, fine.
Why
Yeah.
we are
Yes.
Morning,
good
Kosre.
morning.
Morning.
Okay. Please, while we're waiting for the lecture, it's an appeal to all of us. Let's minimize our noise. Being a quiet environment does not guarantee you will not distract the class. Anybody can barge into where you are, and then you will distract the class. The standard procedure is mute your mic if you are not given the opportunity to talk. mute your mic. When we start calling names, we look as if we are taking a person. But this thing distracts the class, and sadly, the person who is disturbing the class doesn't even know the level of damage the person is causing to us. If I say let's go back and discuss some of these things on the WhatsApp group, some of you will not visit the WhatsApp group for 3 days. And then by the time you come, you lose touch with what all the information that we intended that you should get. So please, it's not even easy. When Desmond or I become the host, we struggle with controlling the meeting and then paying attention to the class. And then the chief host himself is controlling more than one meeting. So you don't expect him to be everywhere. So please, guys, let's respect ourselves. I said I was going to teach the class on how to use Zoom. Most of you refused attending the class because for whatever reason. I think the problem is not who doesn't know how to use Zoom. The problem is those who don't know how to use Zoom and have refused to learn how to use it. We should be above these things by now. We should be above these things now. Even if you don't want anybody to teach you, you are not living alone in your own area. Ask for any smart person who knows how to do some of these things around you to teach you. I feel me or all of us can carry ourselves along. But when it looks as if some people just perpetually want to be left behind, it doesn't make sense. I just have to address this thing here in the middle of the class while we're waiting for the lecturer, because after here, all of you will log out and then we'll not be able to talk about it. This is not good again. This is, I think, the 5th or 6th week. By now, like we should have learned how to operate this thing. And all of us, we even know how to host a meeting. Thank you.
I suggest that the lecturers should always be made the host so that they will be able to mute the mic.
It is not guaranteed for a lecturer to be the host, because they too they struggle with network. So anybody can be the host even without being pre-informed. The system automatically makes someone a host. So it's for all of us to know how to use this thing so that when you become a host, you will not end the class by accident, or you won't be the one distracting, or you should be able to control the class. Anybody should be able to do this. I brought in Desmond so that he will help. And then he has been very, very useful about this. If all of us become a Desmond, then the class will be peaceful. At the end of the day, we will all be assessed, both us and the lecturers will be assessed on how we were able to coordinate ourselves during the class.
Safaya, I suggest if anybody within us is not allowing us to have good class environment, the host, Desmond, should maybe throw that person out. That is twice, probably. We will learn our lessons and we'll learn how to come back and then we mute our mic. If not, it's becoming unbecoming. Thank you.
Good morning, Coach Rep. I'm in support of that, because in the physical class, if you are making noise or disturbing the class, they normally send you out of the class. for others to learn a lesson. Some of us, it's like we don't know what you are here for. And if you don't know what you are here for, allow others that know what they're here for to face the business. The best thing is punishment by throwing the person out of the class. I suggest so.
The truth is we are all classmates here. So doing that is not totally accepted. That's my thought. But then if all of us agree to this, then we will do it. It's our own internal mechanism of controlling the class. That's just it.
Hello, Mr. Jigba. Hello?
Mr. Tapwesa.
You were saying you were contributing something. I didn't hear what you said.
No, it was not a contribution. I wanted to tell the lecturer that I think he was not
lecturer is back.
Treating it the way I will assimilate with him.
Okay, they said the lecturer is back. It's network. The man is trying. It's network.
Okay, yeah.
Wow.
Jennifer Jato, you're the host. You can control the class. You'll be muting the mics.
Okay, thank you, Desmond.
Mm-hmm.
Jennifer, can you do that for us?
No problem.
All right, thank you.
Okay, are we back there? No class.
Hello, sir. We are here.
Welcome back.
We are here, sir.
Okay, the last time I was saying, I went back to what we have started discussing to remind us that we have begun looking at classifications of mental disorders. We have agreed that there are basically two classifications of mental disorders. We have neurotic disorders and we have psychotic disorders. And I told you that psychotic disorders have to do with an individual losing touch with reality. An individual that has lost touch with reality presents symptoms like delusions, hallucinations, distortion in thought, and distortion in psychomotor agility. While neurotic individuals have their reality intact, preserved. So what distinguishes neurosis from psychosis is the manifestation of symptoms by the individual who is under assessment. And we'll say that basically this individual is apprehensive. He presents symptoms or characteristics of anxiety. He develops phobias. He has obsessive thoughts and compulsive behaviors. And we say that these behaviors or these characteristics form the hallmark of distinction between psychosis and neurosis. This is what we have been trying to say all this while, that the network is actually not allowing us. So going forward, we want us to look at common types and the impacts of neurotic disorders. You know, neurosis is derived from, neurotic disorders are derived from the term neurosis. And I say they are mild form of mental disorders that do not, or that preserve the individual's reality. So an individual who has been assessed and diagnosed to suffer neurosis experiences. Wow. What's happening? Experiences generalized anxiety disorder. He also suffers from panic disorders. He suffers from obsessive compulsive disorders. And there are specific phobias that he also experiences or suffers. An individual can suffer from one or more phobias, and there are individuals that are not phobic at all. Remember, neurosis or neurotic disorders do not prevent the individual from having full control of reality, of his thought process, of his psychomotor agility. His thought processes are intact, but what is common is that these fears or this apprehension is there. Now, when we talk about generalized anxiety disorders as one of the neurotic disorders individuals experience or experiences, we're talking about chronic or excessive worry. And studies have shown that 1 in 20 Nigerians suffer generalized anxiety disorders, and they impact his daily living. What constitutes this? The normal stress you experience every day, the stress of what to eat, what the future holds, or what tomorrow holds, can also trigger an individual from developing generalized anxiety disorder. It therefore also means that individuals who are under traumatic attack can experience this form of disorder. We also have another classification of neurotic disorder. We call it panic disorder. They are recurrent and unexpected panic attack. It is often common among people. It's often accompanied with agoraphobia. That's fear of public places. Remember when we were trying to explain what phobias are? See that there are over 50 types of phobias that individuals experience. And one of them is the fear of public places. It is called agoraphobia. So for panic attacks, individuals who experience panic attacks are also likely to experience or to also manifest symptoms of agoraphobia. They have fear, they are experiencing fear of public places. They limit public engagement for fear of these attacks. And also we talk about obsessive compulsive disorder, OCD. It has to do with persistent and intrusive thoughts. We mentioned obsessions, repetitive behaviors, compulsions, and these activities consume time and take away the individual from certain activities. He is doing his activities, but more often than not, he is still in his repetitive behavior. For instance, an individual who feels there are crawling sensations on his body. Repeatedly, he's cleaning or he's scratching that part of the body. He's off what he's doing to scratch that part of the body. An individual who feels that his hands are soiled with dirt. You know, very often he's leaving his task to go wash his hand. Why? Because he is also feeling that his hands are dirty. These are obsessions. These are compulsive. These obsessions come with compulsion, and they cause that individual to engage in obsessive compulsive behaviors. Hence the name of that type of disorder. We also have specific phobias. And we say phobias are intense. They are irrational fears that cannot Are we together?
Yes, sir, we are here.
Are we together to where we have stopped?
Yes, yes, sir.
Do you understand what neurosis is?
Yes, we understand, but your font, the slide of your font was small. Assuming you increase it, that would have been better, sir.
Okay. Noted.
We lost you when you were explaining the specific phobias, sir.
Okay. The emphasis is that these types of phobia vary from one object to another. For instance, we were talking about, we're mentioning angulophobia, which is a fear of public places. People who develop these forms of phobia, are afraid of public gatherings. Also spoke about claustrophobia, fear of clusters. When you cluster in a group, it is not a public, it's not like a fear of public places. But when you relate together in a group, people who suffer from claustrophobia are afraid of such gatherings. We spoke of hydrophobia. This has to do with the fear of water. People who develop fear for water are afraid of even crossing bridges. Are we together? Paddling or crossing the river using a boat or a canoe, they don't dare it because they are afraid of water. It is called hydrophobia. We have well over 50 types of phobias that individuals are apprehensive about. So it depending on the individual situation, and it is depending on the assessment, what the individual is able to express as his own object of phobia. Such phobias are also named accordingly. In our subsequent classes, I can share with us the list of phobias we have so that we can also become very common with them. Have I responded to your question, your concern?
Yes, sir.
Yes, sir.
Thank you.
Okay. Can we make progress?
Yes,
Yes,
you
sir.
can.
Maybe you could just zoom your distance because the background is already dark and it's not really visible. So maybe zooming will be better than increasing the font.
So let's look at psychotic disorders, why I'm also working on that. Let's look at psychotic disorders.
So I have a question.
Yes.
Okay, for someone experiencing postpartum behavior after childbirth,
Yes.
that one falls under what? Is it depression or is anxiety?
Okay, postpartum is a type of depression experienced by a pregnant woman after delivery. For
Okay.
instance, a woman who is experiencing a male child, who has given birth to female children, she is expecting that this pregnancy ought to have been a male child. She is convinced. Maybe she had gone for pre-delivery scan, and they are all pointing to the fact that this is a male child, and she gives birth to a female child. Such a woman can develop what is called postpartum depression. It is depression after birth. It may come as a result of stress. It may come as a result of absence of love and care from family members. So it is a form of it's a form of psychotic disorder and not neurotic disorder.
Okay.
Because you will notice in the presentation of symptoms that such a woman will lose touch with reality.
She will be hallucinating.
She will not be hallucinating.
No, she will not be.
But she will lose touch with reality.
Okay.
Yes.
I'm not explaining, but that's why I asked.
Okay, can we make progress?
Yes, sir. Thank you, sir.
Okay. Looking at the picture on this slide, it's a picture of an individual who has multiple thought process, who is experiencing different situations occurring within his mind at the same time. It is a brief description, diagrammatic description of psychosis. And you know that psychosis is the opposite of neurosis. If neurosis is mild, then psychosis is not mild, it's a major form of disorder. Now, it is a severe disorder that is characterized by a significant break from reality. Individuals who are diagnosed to be psychotic lack insight in their conditions. What can make me agree or conclude that the individual before me is psychotic? In the course of assessment, I will notice he has delusions, false beliefs. These beliefs are peculiar to the individual. They are not upheld by any other person except that individual. For instance, an individual who is diagnosed to be psychotic tells you, as you are looking at me, I am the governor of Benue State. I was once a minister. This is called delusions of grandiosity. Are we together?
Yes, sir.
Yes, sir.
Yes, sir.
The individual tells you that this woman here is my mother, but I don't trust her again. They are planning to kill me. I don't want to associate with them. These are false beliefs. And these beliefs are not held by the person, the caregivers or the relations, but they are held very strongly by the individual. This type of belief is called delusions of persecution or persecutory delusions. Now, these delusions are major signs of psychotic behavior. Now, the individual is lost from his reality. The reality is that these are his relations, these are his friends, and they are providing care and support, but he does not trust them again. You know, there are false beliefs that are held by the individual who suffers mental illness. Then we also have a key characteristics of a psychosis. There are false perceptual beliefs that are also held by the individual with external stimulus. False beliefs, false perceptual beliefs that are upheld by the individual without external stimulus. Now, what do you mean by external stimulus? There are no senses. We have the sense of smell, we have the sense of what? Hello, are we together?
Well, we lost for
No,
the
sir.
past
We lost.
30 seconds.
Pardon?
We lost for the past 30 seconds.
You are lost for the past 30 seconds?
Yeah, your
Okay.
network was kind of cracking.
Okay. But can you hear me now?
Yes,
Yes, sir.
Okay. So let's go back to look at psychosis again so that we can all be on the same page. I have said that psychosis is a major form of mental disorder. It is the opposite of neurosis. Neuroses are mild mental disorders, while psychosis are major or severe forms of mental disorders. They are characterized by a break from reality. The individual loses touch with reality. He lacks insight into what his problem is. Now, when we talk about insight, what do we mean? I'm having headache, or I am having a malaria fever. And I'm simply asked, why do you have malaria fever? I say, probably because I sat outside for some time and I was bitten by mosquitoes. I have insight into what my problem is, isn't it? Somebody comes to tell me, are we together?
Yes, sir.
Somebody comes to tell me that your father in the village is responsible for this. And I will tell him, no. I sat outside for a long time and I was bitten by mosquitoes. I have insight into what my problem is. And someone comes before me, my mother and my brother who brought me to the hospital or the clinic are the ones running after my life. They want me to be killed. They have caused this problem for me. Do I have insight into what my problem is?
No.
Yes.
Do I have insight into what my problem is?
No, sir.
No, sir.
No, sir, at that moment.
At that moment, you don't have insight into what your problem is. So,
Yes, sir.
psychosis, one major thing psychosis does to an individual who suffers this mental disorder is the fact that he lacks insight into his condition. And why is he lacking insight? He's lacking insight because he has broken away from reality as a result of that disorder. Are we together?
Yes, sir.
Yes, sir.
So what makes me
Yes, sir.
identify a psychotic individual? He presents himself with characteristics or symptoms of delusions. And what are delusions? They are false beliefs. They are false beliefs that are peculiar to that individual. The individual holds these beliefs, but they are also not upheld by any other person else. They are peculiar to him. And when we talk about delusions, there are different types of delusions. We have persecutory delusions. We have delusions of grandiosity. Now, persecutory delusions, an individual may tell you his friends are the people behind him. They are persecuting him. The individual may experience or may present symptoms of grandiosity. He is feeling he's a very big man, and you are not recognizing that fact. Are we together?
Yes, sir.
Now,
Yes, Doc.
the individual also presents characteristics of hallucinations. And what are hallucinations? Hallucinations are false perceptual beliefs. Are we together?
Yes, sir.
They are false perceptual beliefs. Why are they perceptual? They are perceptual because they are coming from the five sense organs. And I was saying we have 5 sense organs. We have the eyes that enable us to see. We have our ears that enables us to hear. We have our tongue that enables us to taste. We have our nose that enables us to smell. We also have our skin that enables us to feel sensation, isn't it?
Yes, sir.
It is.
Now, we have 5 types of hallucinations. The first type of hallucination is called auditory hallucinations. It is coming from our sense of hearing. Now, an individual who is psychotic presents with auditory hallucinations. He can present with auditory hallucinations. He hears voices that no other person hears. He tells you they are here. They are asking me to come out. And when you turn around, you will not see these people and you cannot hear these voices. We term that as auditory hallucinations. Are we together?
Yes, sir.
We also have gustatory hallucinations. The individual perceives odor, perceives smell that is peculiar with him without others experiencing such. Are we together?
We lost that one. I lost that one. The second one.
Okay, gustatory hallucinations.
Okay.
It has to do with smell, odor. You are perceiving aromas that are peculiar to you or smells that are peculiar with you, and they cannot be perceived by others. Can we make progress?
Yes, sir.
Yes, sir.
Yes.
Hello, class.
Hi, sir.
Hi, we can hear you,
Yes,
sir.
yes.
Hi, sir. We can
Hello,
hear you.
Doc. We can move on.
Hello, sir.
Are we together?
Yes,
Well,
sir.
with you, sir.
Yes,
Yes,
sir.
sir.
Okay,
Yes,
we
we are
also
together.
have what is called visual hallucinations. Visual hallucinations. You are seeing things that others are not seeing.
So we do.
Pardon?
Yes, sir.
Can you hear me well?
Yes, sir.
Yes,
Very
sir.
well,
We
sir.
can hear you.
Okay, so hallucinations experienced by psychotic individuals are related to the 5 sense organs. It can be auditory, it can be visual, it can be gustatory, it can be olfactory hallucinations, it can also be hallucinations arising from our sensations. Tactile hallucinations. Sensation has to do with your skin, isn't it? You
Yes, sir.
experience crawling sensations on your skin that is peculiar to you. That something is crawling on your skin. You are the only person seeing it. You say, look at it moving here. It is not there. These hallucinations, these experiences are peculiar to the psychotic individual and not every other person. Then, apart from hallucinations, there is evidence of disorganized thought. There is evidence of disorganized thought. The individual's thought process is disorganized. He begins a speech, he gets into another subject, and before he ends one sentence, he has brought in 4 or 5 different subject matters. Are we together?
Yes, sir.
Yes, sir.
Now, in this organized thought, we talk about thought disorganization. The individual's thoughts are not coordinated. And if the thoughts are not coordinated or the thought is not coordinated, definitely the speech is also going to be disorganized. Are we together?
Yes, sir.
Now, there is also presence of disorganized speech. And when there is disorganization in speech, we evidence things like word salad, thought broadcast from the individual you are assessing, or from the individual you have diagnosed to be psychotic. And then there is also evidence of bizarre behavior. Bizarre behaviors are abnormal behaviors, abnormal postures. You know, you adopt a particular posture or a particular look that is abnormal, that is not normal. For a normal human being, it is expected that you You look at an object or you look at a person and then you take away your face, isn't it?
It is.
It is.
And then you are focused on that person for more than 30 minutes, for 1 hour without blinking, it is a bizarre behavior. Or you adopt a particular posture by the roadside or anywhere and you balance there for a very long time. It is called bizarre behavior. This type of behaviors, they impair our daily functioning and leading to a significant impact on our social and occupational functioning. So an individual who is diagnosed to be psychotic has his daily functioning impaired. Daily functioning like eating of food is impaired. Normal daily hygiene is impaired. Normal daily routine household activities are also impaired. Now, socially, there is a distortion. Occupationally, there is an occupational challenge because the individual cannot be focused on tasks that are given to him. Are we together?
Yes, sir.
Yes, sir.
Have you understood to this point?
Sir, but
Yes,
I
sir.
have a question.
Yes.
Okay, thank you, sir. Given the understanding of auditory hallucination and maybe visual hallucination, can we say it's in all situations that it can be said that one is experiencing psychosis, given our deep understanding of when there is particular sickness? I don't know if it has English name anyway. Akumbwagene, where most time young girls shouting ho 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 ho, and then during that time they hallucinate. They see sensory things. They will be like, they're coming, they're saying I should do this, I should do that.
Yes.
Now,
We can call that visual hallucinations. We can call that visual hallucinations.
Okay,
but
now my
not
question
all
is,
psychotic
can that actually
individuals
be said?
experience visual hallucinations. A psychotic individual can experience visual hallucinations, auditory hallucination, tactile hallucination, olfactory hallucinations, and all the forms of, or the types of hallucinations. Another psychotic individual may only experience auditory hallucinations. Another psychotic individual may experience 2 or more of these hallucinations. Now, for cultural variations, in relation to your question, those girls shouting suffer what we call cultural bound syndrome. It is a form of disorder that is cultural bound. And there are specific disorders that are specific to certain cultures.
Okay.
Have I answered your question?
Yes, yeah, with that is very clear, because I was wondering if we could just say that is that some form of hallucination and link it to psychosis. I will now be confused, given the understanding of what DSM-5 talks about duration. There must be an established duration before we can say that this person is experiencing a disorder. But if you notice in that cases, most time that happens within a short period of time. Maybe the girl just shout that thing for just like sometimes 10 minutes, sometimes 30 minutes, and after that, they are fine again. So it will be difficult to say that these people are actually having psychosis, because after that experience, they function normal in the society. They don't seem to have any loss of touch with reality. So I was I was finding it difficult linking them with this psychosis disorder.
Yes. There are different forms of disorders, and individuals with this form of disorders can experience one form of hallucinations or the other, depending on the severity of their own conditions. But the condition mentioned is a cultural bound syndrome. It's a syndrome. And one common characteristics with that cultural bound syndrome is the presence of visual hallucinations, because they see They see persons that you cannot see.
Okay, okay,
And
okay.
that does not mean they are suffering from psychosis.
Very good. Oh, that's fine.
It's all right. Can we make progress?
So
Yes, sir.
you failed to mention to discuss much on olfactory issue. You mentioned olfactory there, and you didn't
Okay,
throw more
olfactory
light on it.
hallucination has to do with your nose,
Okay, sir. Okay, sir. I have this.
what you smell.
Hello, sir.
Now, olfactory hallucinations has to do with a situation where a psychotic patient is before you.
Hello,
and he's
sir.
telling you, I am perceiving an odor
Hello, sir.
that no one else is perceiving.
Okay.
It has to do with your sense of smell. And it is
Okay.
peculiar to that psychotic patient.
Okay. Notice that. Thank you.
It's all right. Can we make progress?
Yes, sir. Sir,
Yes, sir.
there's this issue I want to ask. I am not very clear about. There was a
Yes.
time. Yes, there was a time I had.
Can you go ahead?
There's a time I had some pain in my legs. So this,
I'm with you.
I'll feel movement from the other leg to pass and go to the other one. So was that a kind of hallucination or what? Hello, sir. Hello.
Hello.
So I felt pain moving from one of my legs to the other leg.
Hello.
Yeah.
So we can hear you, sir.
Okay. Okay, sir. But I
Hello.
hope you understand my question.
Hello. No, from the side. From their side.
Sir, we can hear you now.
Okay, you can hear me now, right?
Yes, sir.
So, okay. So very quickly, I want us to look at the types of psychotic disorders and how they impact our daily functioning. The first one we very briefly going to look at is called schizophrenia. Schizophrenia. Now, every culture has a name for schizophrenia. Why your culture may not be able to differentiate one mental disorder from another, this class is going to help you understand that there are different types of mental disorders. And the first one, it's called schizophrenia. It's a chronic and severe brain disorder. A chronic and severe brain disorder that results to loss in touch with reality. It is characterized by loss in touch with reality. Are we together?
Yes, sir.
Are we together? Before now, authors have said that have defined schizophrenia as a split in reality. Now, if you look at the picture before us, you look at this individual having a split form of reality. From one side of his thought, he's thinking something else. From the other side of his thought, he is having a different form of reality. To look at the third, the second picture, the individual is divided into three. The same individual has three forms of personality. Are we together?
Yes, sir.
Yes, sir.
It therefore means that an individual who suffers schizophrenia loses touch with his own reality. He has an identity crisis, identity issues. He finds it very difficult to coordinate himself. There is presence of speech disturbance. There is presence of thought disturbance. There is presence of psychomotor disturbance. There is emotional disturbance. There is distortion in personality. All this happens to this same individual. Now, in Nigeria, 1% of Nigerians suffer schizophrenia. 1% of Nigerians suffer schizophrenia. And there are up to 5 different types of schizophrenia. We have catatonic schizophrenia. We have the disorganized type of schizophrenia. We have hebephrenic schizophrenia. We have paranoid schizophrenia. We have undifferentiated schizophrenia. Now, all these disorders are lumped up onto schizophrenia. What makes them different is the unique characteristics or unique presentations of individuals who have these disorders. Now, the DSM-5 gives us specific inclusion and exclusion criteria for diagnosing individuals with this type of schizophrenia. It is a major form of disorder that affects an individual by causing him to absolutely lose touch with reality. Are we together?
Yes, sir.
Can I make progress?
Yes.
Yes, sir.
Now, the next type
I
of
was
psychotic
thinking you made mention of the types of schizophrenia and you called them out properly for us to write. But then you just rush and they are not on your slide. That's my worry.
Okay,
Thank you.
catatonic schizophrenia.
Yes, sir.
Hebephrenic schizophrenia.
Yes, sir.
Paranoid schizophrenia.
Yes, sir.
Undifferentiated.
Yes,
The undifferentiated type of schizophrenia.
Yes, sir.
And the residual type.
Okay, sir.
Are we together?
Yes, sir.
Paranoid, catatonic, residual, undifferentiated, disorganized type.
Yeah, okay, sir. Thank
Can
you.
we move forward?
Yes, sir.
Yes, sir.
Then we have what we call the schizoaffective disorder, which is also a type of psychotic disorder. This type of this psychotic disorder combines symptoms of schizophrenia with mood disorders. It combines features of schizophrenia with that of mood disorders. We have a bipolar disorder. We have bipolar 1. This type of disorder comes with features of mood episodes, or it comes with a features mood episode in its presentation.
So what is mood episodes, please?
Okay, mood episodes are various sensations in mood. There are up There are upper moods or elated moods, which we call mania, and there are low moods, which we call depression.
All right.
And they are accompanied by psychotic symptoms and severe emotional disruptions. Now, an individual who presents with bipolar 1 disorder, you will notice on one day of assessment, he is so elated, he is so happy, overexcited, hyperactive. That's the manic state. Then on another day or within a short given time, you access the same individual, he is on a low ebb, presenting symptoms of depression.
Excuse me, sir, is this the same thing we refer to as mood swing?
These are not mood swings, but they are similar in nature. Mood swings don't last. They don't last the duration of manic and depressive episodes. Have I answered you?
Yes, sir.
Then we have delusional disorders. Remember, we have spoken about delusions, and we say they are false beliefs that are peculiar to the individual. Now here, we have delusional disorders. And delusional disorders are characterized by non-bizarre delusions, and they last for a period of 1 month, at least for 1 month. Can we make progress?
Yes, sir. Please, I have a question on
Yes, okay,
schizophrenia.
go ahead. Yeah.
Okay, sorry. I don't know if the um experiences that comes with old age can be said to be schizophrenia, because there's hallucination, there's delusion, there's inability to comprehend effectively, there's sometimes memory loss and all of that. So I don't know if that can be seen as schizophrenia or if it's a disorder that has a name.
Okay,
Of
there are
its own.
disorders of there are disorders of old age.
Okay.
It's a disorder of old age. Young people that suffer dementia are those who are involved in serious traumatic events that have impacted negatively on their brain functioning, or they have suffered protracted or chronic illnesses, that have actually affected their functioning. So what old people experience is what we call dementia and not schizophrenia.
Okay,
That does not invalidate the fact that we have old men who have suffered schizophrenia. Have I answered you?
yes, sir. Thank you.
Okay. Let us very quickly look at causes and contributing factors or contributory factors to schizophrenia, not just schizophrenia, but psychotic disorders. These factors can be explained using what we call the biopsychosocial model or the biopsychosocial variables. Biopsychosocial in the sense that we have biological factors, we have social factors, we have psychological factors that impact, our functioning. Are we together?
Yes, sir.
Yes, sir.
So Yes, so while discussing causes of psychopathology, you were also able to discuss causes of psychopathology that are related to causes and contributing factors of schizophrenia. Then under the biological factors, we have genetic predispositions. Now, you all go back to recall our biology class, where we were looking at, where we had studied chromosomes. Are we together?
Yes, sir.
Yes, sir. We are.
So in our biology class back in the secondary school days under reproduction, we were told that before a child is born, the father and the mother contribute chromosomes, certain genes called chromosomes. And these chromosomes carry genetic traits of the father and of the mother. So the man contributes 23 pairs of XY chromosomes, while the woman contributes 23 pairs of XX chromosomes. Now, these chromosomes carry genetic composition or predisposition of an individual. So when a child is given birth to, the child either resembles the father or the mother, or the grandfather or the grandmother or the auntie. Now, it is because there are genes within these individuals that came together. Now, studies have also shown that, I've explained that abnormal behaviors are genetically predisposed. That an individual whose parents have one form of mental disorder or the other can transfer these mental disorder genes onto their offsprings. So the genes can be recessive or they can be dominant in the individual. Are we together?
Yes, sir.
It therefore means a young man or a young lady who has come from a family where there is a family history of mental disorder has likelihood chances of also developing mental disorders in the course of his development. We also have chemical imbalances or imbalances in brain chemistry. In your first lecture, I listened attentively as Dr. Dorothy was mentioning neurotransmitters like dopamine and serotonin. Was that what happened?
Yes, sir.
Yes, sir.
Yes, any causes of psychopathology. And she was talking about chemical imbalances as a cause of psychopathology. When there is excessive release of these chemical imbalances, they result to psychopathology. If you look at the diagram of a nerve cell, when you look at the diagram of a nerve cell, at the tail end of that nerve cell, where you have the terminal axons that connect one neuron to another, you will notice that inhibitory and excitatory functions take place at the terminal axon, where neural messages are transferred from one neurotransmitter to another. Now, in the course of transferring neurotransmitters or neural messages from one neural impulse to another, the neurons perform either excitatory or inhibitory functions. So for dopamine as a neurotransmitter, studies have shown that excessive release of dopamine into the system results to psychopathology and results also to abnormal behavior. Are we on the same page?
Yes, yes.
Yes, sir.
Yes, sir.
Okay. Now we have psychological factors contributing to abnormal behavior, or psychological factors contributing to the onset of psychosis. And what are those psychological contributors? We have trauma. You have recently all witnessed the genocide that took place at Yelwater. Is there any of us that is unaware of that genocide?
So we're aware.
I think we are all fully aware.
Good. Now, people who have been who survived that attack will develop trauma. It will begin from acute traumatic disorder, stress disorder, to post-traumatic stress disorder. There is a likelihood that one out of 10 who suffer traumatic experience may also develop psychosis. And then we have also psychological contributors like childhood abuse. There are some of us who have brought children from our villages, our cousins, or we went to our villages, we got people to come stay with us. And while they are staying with us and our children, we have felt that they are third-class citizens and not second-class citizens.
Yes.
Are we together?
The biscuit
Are we together?
Yes, sir.
Yes, sir. Madugu Salas, mute your mic.
We subject them to a lot of abuses, such as sleeping very late while your children are sleeping. They work till late night by 12 midnight, 11 midnight. You wake them up by 4 a.m. to continue with normal domestic chores. Then you send them to the least standard school within the environment. You know, over time, it has been observed that public primary schools are meant for children, for wards or children whom we have brought from the villages. Now, the child begins to imagine he has a home, he's coming to stay with someone, he's working for you, he's doing all of these things, and you have subjected him to this kind of inhuman treatment. It's an abuse. This can result to psychosis. Are we together?
Yes, sir.
Then we have severe stress. We have severe stress. Stress is a psychological factor. When an individual is unable to respond positively to stressors, to stimulus that is impacting or impinging on his sensory system, we can say that such an individual has stress, is suffering from stress, or has developed stress. His inability to manage his stress, can also result not just to health concerns, but also psychosis. And we also have what we call personality traits, personality issues. Gordon Allport in 1969 defined personality as the persuasive characteristics of an individual that manifests itself in social distinctiveness. The persuasive characteristics of an individual that manifests its social distinctiveness. Persuasive because personality traits pushes you to behave the way you behave. So they are persuasive. So when you want to do certain things and you have an inner push to do it the other way around, your personality trait is at work. It is pushing you. And when it pushes you, it manifests in different dimensions. So you have dual personalities. You have one personality in the church. When you go to church, you behave well. You have one different personality when you are with your friends in a social gathering. Then you have a different personality when you are at home with your family. So you see one individual manifesting different forms of personality. So the manifestation of your personality traits can also push you to develop psychosis. It's a contributory factor to development of psychosis. Now, when you are within a group of people, your age mate, and you have developed a negative personality, you feel that, oh, all my mates have all made it in life, and then you become withdrawn. It results to psychotic disorders, gradually slice into psychotic disorders like depression. Are we on the same page?
Yes, sir.
Then we have our social environment. Then we have our social and environmental factors contributing to psychopathology or contributing to psychosis. Poverty. You know, before now we said poverty is not an illness, but you know poverty is an illness. Are we together?
It's
Yes,
still a
sir.
terminal
Yes,
illness.
sir.
Yes, sir.
Well,
It's even a terminal illness, isn't it? So, you know, poverty can trigger an individual to behave in abnormal ways. And then we have factors like urbanization. Everybody wants to be a town boy. Everybody wants to catch up with modern trends in technology. Trying to meet up with societal demands with limited ability can result to psychopathology. Have we observed the pathological issues surrounding the Yahoo boys who wants to graduate from ordinary Yahoo boys to Yahoo Plus? Hello?
Hi.
Yes, sir.
Hi, sir.
Are we on the same page?
Yes, sir.
Yes,
Yes, sir.
We have substance use and substance abuse.
yes, sir.
You know, it's very easy to say, I have known my neighbor who has been drinking for years, and he's very normal. Your body physiological composition may be similar in structure and information, but may also differ in ability to contain psychoactive substances. Now, in our study of physiological psychology, we have come to understand that as you travel along the road and you see various checkpoints, trying to inhibit and prevent, you know, criminals and the bad people from passing without being on check. The human brain also has a security checkpoint. We call that the blood-brain barrier. Now, what the blood-brain barrier does is it serves as a security check for fungi, for bacteria, for viruses, and for every other thing that is going to alter our normal body physiology. Unfortunately, alcohol and psychoactive substances beat that check because they flow in a semi-permeable membrane. They beat this check to alter our state of consciousness. And it is a serious trigger to the onset of psychosis. So psychoactive substance use and abuse can stem from ordinary beer, to spirits, to marijuana, to cannabis, heroin, opiates. As the list continues, there are serious triggers to the onset of psychosis. Are we together?
Yes, sir.
Yes, sir.
So there is also the fourth factor, which is called the Nigerian context. And the Nigerian context as a contributing factor to the onset of psychosis has to do with our socioeconomic stressors, limited access to healthcare facilities, and quality healthcare.
Funny but true.
And then we have cultural stigma. Every one of us comes from a culture, and we have cultural beliefs that we have hold so dear to our hearts. And these traditional beliefs, they influence our perception of mental illnesses. In your initial class with Dr. Dorothy, I heard her telling you a story or stories of how people were taken to religious houses who have mental illnesses. And they were flogged with the belief that mental illnesses, when flogged, they leave the individual. Are we together?
Yes, sir.
Yes, sir.
These and many others that are not mentioned are actually causes and contributory factors to psychosis. Psychosis or mental disorders are classified using what we call the DSM. And
So maybe
as
we
at
can
today, pardon?
Maybe we can continue after break.
Okay, we want to proceed for break, right? Our break, we are resuming.
Excuse me, sir.
1. It's all right. So we can proceed for break and resume by 1.
So this lesson was interrupted now. We kept going and logging out and in.
We are going for break. We'll come back for break. Which one is?
So can we
Yeah, I
proceed
have a
on break
question.
and return by 1 o'clock?
Yes, sir.
Yes, sir.
It's all right. Thank you.
Someone is saying she has a question.
It can be after break.
Please, can you note your question? We'll take your question after break.
Okay. Thank you, Doc.
Thank you.
Hello, sir.
Thank you.
Come on.
Thank you. Sorry for disturbing.
No, it's getting free knowledge.
Sorry, let me
Mr. Desmond.
Yeah, fine.
Mr. Desmond.
Yeah, fine.
So, see, me, I will keep telling you guys this thing. A lecturer is talking and then you interject him and then you are telling him that it's time for break. It doesn't make sense. Let's be more respectful. Me, I'm telling you people about these things. I will not be going back to talk this thing on the WhatsApp group again. If it happens, let it be on record that me, I'm saying it. It doesn't make sense.
I have this thing. I think the break will be necessary because we need to power our devices so that we can continue later when the break lasts.
Chago, I think you're the one. Were you the one that said that? No, it doesn't make sense. Let's respect people. He was talking. Let him land somewhere. No, let him land somewhere. I don't like that. This is the second time we are doing this thing.
I think that's the wrong approach.
It does, yeah.
Let's end the meeting, please.
Excuse me, fire. Good
Let's end the class.
Excuse me. Please, can the admin end the class? Let the admin end the class, please.